Today we will be learning about the next class of antimicrobial, that is aminoglycosides. Do you think they are better than the penicillins? Which is better, penicillins or cephalosporins? Carbapenems or cephalosporins? Okay. So, which are bactericidal? Penicillins? Both are bactericidal. Aminoglycosides, they should be cidal or static. Why do we have both the drugs? We use both static drugs, cidal drugs. What is the reason? Though we have the cidal drugs, we also use the static drugs. Okay, we will be learning about that. In the meanwhile, you just put some work to your brain why we do so. Okay, so introduction. Aminoglycosides are the group of drugs, antibiotics which are used in the treatment of bacterial infection, and they are mostly against the aerobic gram-negative bacteria. Penicillins, cephalosporins, again they were gram-positive, gram-negative based on their generations. Okay, so we need to remember we are using it on more on aerobic bacteria here. They are less penetrable into the anaerobic tissues. Anaerobic bacteria. So it consists of 2 or more amino sugars and a hexose nucleus. So amino sugars linked by amino cyclical, which is a non-sugar. And the demerit or the limiting factor here is the ototoxicity and nephrotoxicity. Okay, so because of this, we use them in a limited conditions where the other drugs may not be that much helpful. So streptomycin in 1943 it was found by Scotts Boogie and Waxman. Here you can see Waxman. So these are the pioneers who started thinking that some of the mouse can kill bacteria. Okay, so mouse are nothing but the fungal organisms. So here you can see how the structure of this aminoglycosides is there. Just a brief idea. Okay, so 2 amino sugars are there. In between there is an amino cyclical ring, that is deoxystreptomine. Okay, most of the aminoglycosides has this structure, except for our streptomycin, where the amino cyclical ring is placed on the sidewards, and both these sugars you can see here, streptose amino sugar and glucose amino sugar, they are placed on one side. Okay. So the streptomycin part is on the lateral part. Okay. And we call these 2 sugar units as a streptobiasamine. Okay. So these basic terms we need to remember, like when they have given for main question, we need to concentrate 2 amino sugars linked by amino cyclical ring. It is in between the 2 amino sugars in most of the sugars, whereas in our streptomycin it is placed laterally, that is streptidine, which is the amino cyclical or non-sugar part, and 2 sugar units together they call them as streptobiasamine. Here sometimes it happens that we use MyCIN or MICIN. Okay, that's how we need to concentrate why we use it. Okay, here the nomenclature is based on the origin. Okay, here those obtained from the streptomyces, we have the suffix mycin. From Micromonospora we have the suffix mycin. Okay, MICIN. Okay, so MICIN, that is gentamicin, amikacin and natilmycin. And streptomyces, we have streptomycin, parvomycin, neomycin and tobramycin. So streptomycin was the first prototype drug which was discovered. It will be uploaded. Okay, just concentrate here. So aminoglycosides, we have both systemic and topical drugs. Okay, streptomycin, gentamicin, kanamycin, amino acid, capromycin. Or you can see very few MICINs are there. Okay, sisomycin, amino acid, and gentamicin. Sopramycin, we have the ointments. Sopramycin topical ointments is also there. And for topical, particularly only for topical, we have this neomycin and carmycin too. Streptomycin, the drug for tuberculosis. Gentamicin, urinary tract infection. Amino second line drug for tuberculosis. Sisomycin, topramycin, netilmycin, these are the reserve drugs. Okay, Pharmacology, sometimes they are used for severe bacterial infections. And we have this sopramycin and neomycin, most commonly used topical antibiotics. So what are the properties of this group? Okay. So these are highly ionized compounds. Okay, you can never get a tablet of streptomycin or any other aminoglycoside group. Okay, the main property we need to remember are these are highly ionized molecules and their tissue penetrability is limited by this factor. Okay, so as they are highly ionized, they are less susceptible for the biological enzymes and less metabolized. And these are highly soluble in water and are stable for months. They are excreted unchanged in urine. Yes, this is what we want when we treat a patient for urinary tract infections, where the drug should reach the particular site of action in its active form or the form in which it is needed. So that's why we find its use in urinary tract infections. So all are bactericidal and most are active at alkaline pH. So you need to remember in urinary tract infection the bacteria produce acidic environment. So the pH will shift towards the acidic environment. So we need to use the alkalinizer so that our drug can be more beneficial. So that is there. So act by interfering with bacterial protein synthesis. So those drugs which are we have read previously, those are cephalosporins and penicillins, they used to act on the cell wall. Okay, once the cell wall is disrupted, they are bactericidal. But those drugs which are acting on this protein synthesis or on the 30S or 50S, most of them are bacteriostatic. But here is a drug which is acting on this protein synthesis. Okay, bacterial protein synthesis, but still they are bactericidal. Okay, so they are active against aerobic gram-negative bacteria, that's term refers. Okay, they have the partial cross-resistance. That means if you are using starting with gentamicin acid, you may, and using it for a long time, you can also get the resistance for rest of the drugs, maybe sisomycin, capromycin, all those things. Okay. So narrow margin of safety. This is very important point because they can attain high plasma concentration, they have post-antibiotic effect, and they are excreted renally in its unchanged form. What can happen if there is renal problem or renal clearance is not good? There will be accumulation of the drug. The usual pH or the plasma half-life of these drugs is about 1 to 3 hours, max by 4 hours. But if there is some impairment, it can go up to for 28 hours, 48 hours like that. Okay, that means approximately 2 days. And there will be particle uptake and it can damage the kidneys. So narrow margin of safety, and that's why we use a new term here, therapeutic drug monitoring or TDM. Okay, so just keep that word term in the mind, we'll come to that. So all exhibit ototoxicity and nephrotoxicity. So this is the reason why we avoid these drugs in pregnancies. Okay, all these aminoglycoside groups are contraindicated in pregnancies. So post antibiotic effect. Here is a drug where the THF is very low, like 1 to 3 hours or 1 to 4 hours. Why do you need to use such a drug where the frequency may be going from 4 to 6 times a day? You are getting? Because we have 24 hours in a day, and here is a drug which can act only for 3 to 4 hours. So, how many times we need to administer the drug? 4 hours, 24 by 4, 6 times. So, still we are using the drug. We are using the drug because of this property, that is post-antibiotic effect. Okay, though the drug stays in the plasma, or the minimum inhibitory concentration of the drug is about 1 to 3 hours in the plasma, we use this drug because they have post-antibiotic effect. That means here a drug which can block the protein synthesis, and once it is blocked, its action can stay there for 24 hours, a minimum of 24 hours. Okay, so they can possess significant post-antibiotic effect and continues to suppress the bacterial growth for several hours after the following the minimum inhibitory concentration. Have you heard this term, minimum inhibitory concentration? MIC. Have you heard of MAC? Okay, so it was a minimum alveolar concentration which was required for anesthetic agent to be effective at least in 50% of the patients and helpful even for the painful stimuli or the surgical stimuli. So, in a similar way, we have term for all the antimicrobial agent. The term is minimum inhibitory concentration. Okay, so if a drug has lowest minimum inhibitory concentration, that means the drug is more effective and also less toxic. Okay, so the amount of the drug which we use should always be less. Okay, if it is less, then only the drug will be less toxic. Okay, so that principle we need to remember. Here, the dosage what we need to give here in this aminoglycoside group is about 2 to 3 milligram per kg body. Almost all the drugs, except for amino acid, where we give 10 to 15 milligram per kg per day. Okay, in divided doses. So single daily dosing is at least effective as no more toxic than multiple dosing, because this concept has come because initially we were thinking that the drug has very short half, so at least we need to give 2 to 3 times daily. That was the principle. So when we got to know that there is a post-antibiotic effect, we started using the single dose, full dose. Okay, for example, the total dose we expect is about 2 to 3 milligram per kg. We calculate it to be 500 milligram, and it should be given in divided dose. But what we did was we started experiments like we give complete dosage at a time. See what will happen. Here in the renal cortical tissue, we need to remember it's a renal toxic drug or a nephrotoxic drug. So this toxicity can be accumulated and can cause severe problems. That was the question. So when we tried it, what happened was we got to know that the renal cortical uptake is a capacity dependent saturable process. That means, in simple terms, a single dose, a maximum dose can be more effective, kill more bacteria at a time. Okay, we can kill more bacteria at a shorter interval of time, and also there is less possibility of the toxicity. Okay, enhanced, and the bactericidal activity is enhanced with the single complete dose. And we have the term here concentration dependent killing. Okay, the concentration dependent killing means more the drug available at the site of action, rapid will be the killing process. It can kill more bacteria at a particular rate. So you need to remember two terms with this: most antibiotic effect and concentration dependent killing. So mechanism of action, here we already got to know that here it is acting with the inhibiting with the protein synthesis. Okay, so any protein synthesis we need to have an initiation complex. So this initiation complex formation is blocked. Okay, so this initiation complex formation is blocked at the 13S ribosome. Okay, so the transport of aminoglycoside we need to remember what is that is passive diffusion. Okay, this passive diffusion can take place in the aerobic bacteria. Okay, so the transport of the aminoglycoside to the bacterial cell wall and it is binding to the ribosome and resulting in inhibition of the protein synthesis. So it is acting on the 30S ribosome. Okay, there we have two drugs. One is tetracycline, one is aminoglycoside. They are acting on the 30S. Okay, so you can remember as 30, 80. Okay, simple, or you can make your mnemonics. So it acts on bacterial 30S ribosome and destroys the messenger RNAs. Okay, thereby prevent the formation of normal complex required for the protein synthesis. The initiation complex is blocked. Thereby, the further chain formation is blocked. Okay, so different aminoglycosides they can cause misreading at different levels. Okay, based on their affinity. They can also combine with the anionic membrane groups and damage the bacterial cell membranes and cause bleeding of proteins, amino acids, and they can also block the Krebs cycle. So, because of this action, it can be bactericidal. So here you can see the mechanism. Okay, so here on the blue line you can see here there is aminoglycoside which can come and act on its 30S. Okay, we have this side. So once it is blocked, what can happen? Block of the initiation process, premature termination, wrong amino acid incorporation, and it can cause misreading and premature termination. So all these effects we need to remember: block the initiation, premature termination, wrong incorporation. So I will put a small diagram to show you which are bactericidal, which are bacteriostatic. Okay, this diagram you need to remember till your exams. Okay, so beta lactams you already read, and we are today dealing with the aminoglycosides, and we have vancomycin, quinolones, rifampin, and metronidazole. So examples for bacteriostatic, we have this. Chloramphenicol, it is a broad spectrum, erythromycin, clindamycin, sulfonamides, the sulfa drugs, trimethoprim and tetracycline, it is a broad spectrum. Okay, you need to remember tetracycline is also a drug which is acting on 30S. Still it is bacteriostatic but a broad spectrum drug. So one more diagram. Here you can see on 30S we have the drugs, aminoglycosides, tetracycline. On 50S, rest of them. Okay, you need to remember just the drugs which act on protein synthesis and drugs which can act on 30S. The rest will be the drugs acting on 50S. Okay, so chloramphenicol, macrolide, lymphosomides, lenzulin, and streptogramins. Okay, most of them are acting on 50S. Can a bacteria develop resistance against this drug? Yes. The concentration of a drug less than the minimum immediate concentration. If it is present for longer time, there can be resistance for any drug. Okay, so that's why we always prefer to give a drug at its optimal dosage and for optimal duration. Okay, so that's why the resistance features have occurred, and it is not so that it is the only feature, but in majority of the cases, the concentration less than the minimum immediate concentration and also lesser duration than the actual required duration. These are the factors, like for example, when private practitioner is there, without knowing complete dosage or without knowing complete duration, you give the treatment for just 2 days, 3 days, and sometimes it so happens that the patient may not be willing to purchase the full drugs what the doctor has prescribed. So what will happen? There is a drug concentration within the plasma which is less than the minimum immediate concentration for shorter duration. So you are not completing the dosage completely, for example, at least for 3 to 5 days, 7 days to 15 days in case of urinary tract infection. What can happen? There is always a chance of resistance. So whenever you are advising the patient, you should always tell them complete the course. Otherwise, I need to give you a higher antibiotic next time and it will be more costlier. Okay, the first type of drug which we use, like for example, AMINOGLYCOSIDES, these are damn cheap. Okay, gentamicin may cost you less than 10 to 15 rupees, or amikacin up to 50 to 60 rupees. Okay, these are the costs which are at lower level, all of them can afford. But if we are bypassing this, not taking the active dosage, what can happen? You need to go for higher resistance drug, maybe piperacillin, tazobactam, which costs you maybe 400 to 500 rupees per single dose, which should be given for 3 to 4 times daily and for 7 days. Tell them, if you don't take this correctly, next drug which we give, may cost you more than 5,000 rupees. Okay, you need to scare them sometimes so that they keep up with the accurate dosage. So here this is the thing which is happening, maybe a plastic mediated inactivation of the microsomal enzyme. So once there is plastic mediated inactivation, the drug will not be that effective. So the pouring channels through which it enters, that will be blocked. Okay, failure of the drug penetration and mutation of the pouring channel, the acidification inside the cell is blocked. So if it is blocked, if it cannot go inside the cell, there is no question of blocking the protein synthesis. So that's why what we do, we use a surplus pouring or a penicillin group drug along with gentamicin. So what will happen? This surplus pouring or the penicillin group drug, they can disrupt the cell membrane or cell wall. Once it is disrupted, what will happen? Gentamicin can directly go inside. Okay, so this principle or the secretion blockade system which helps to clear most of the infections. What was the drug which was used to enhance the activity of this penicillin or surplus pouring group? Probenecid, which can decrease the excretion, increase the plasma bioavailability. So you use the probenecid, you use the penicillin or surplus pouring, along with that you use the gentamicin. So both sided drugs which can stay there for longer time, that can be beneficial. So synthesis of metabolizing enzymes, the drugs which can metabolize this gentamicin, amikacin, those are with the help of this acetyltransferation and acetyltransferase. The acetylation of the drug happens, or phosphotransferase, phosphorylation happens, or adenyl transferase, adenylation will happen. Okay. So mutation may alter the ribosomal binding site for the aminoglycoside. That is at the P site or where the 30S is binding, there can be problems and the drug may not be no longer be able to bind. Cross resistance is also observed. So if a drug is the bacteria has become resistant to the top class drugs, such as streptomycin, amikacin or genta, the subsequent class may not be that much helpful or the resistance can be seen with those also. So pharmacokinetics, we already told that these are highly polar molecules, and the favorite question of the examiners will be, what is the cost of tablet of gentamicin? And most of your seniors have answered this question, and all of them are wrong. You will never get a tablet of gentamicin, amikacin, or any aminoglycoside group of drugs. Keep it clear in the mind, okay? Because these are highly agonist drugs and they are only given by intramuscular or intravenous routes. Okay, so you will never have a tablet of this group. So high polar basic drugs with poor membrane permeability. That's why they have poor oral bioavailability, and we do not prescribe them by that route. So usually the route is intramuscular or intravenous injections, and the maximum bioavailability Cmax is attained within 30 to 40 minutes. Okay, so p-half is about 2 to 3 hours, and we also know that we have the post-antibiotic effect. In case of renal insufficiency, the p-half will be enhanced up to 24 to 48 hours, and absorption increase in inflammation. Okay, so this is important point. If there is some inflammation in some part, okay, there the concentration may be seen at higher ratio. Okay, that is what we need. If there is some sepsis, some infection, we need the drug there. But this drug has poor CNS penetrability, that is one of the demerit, or it cannot, oral drug cannot reach the intraocular fluid. So the plasma protein binding here is minimal. The plasma protein binding here is minimal. We need to think of two things. We need not give unusual excessive dosage to make the very different concentration. Whatever the drug we have given, that is our one part. And also, what? If there is plasma protein bonding, what will happen? There is slow release of the drug into the plasma. Okay, that principle is also not there. That means the drug effect may not last longer because of plasma protein binding. Okay, no significant amount is secreted in the bloodstream. That is, in the most severe cases, we can try this drug if there is a urinary tract infection, and the volume of distribution is approximately about 25%. Okay, so very less volume of distribution. Okay, so that means in most of the tissues where it is not penetrated, it doesn't penetrate, these drugs are less helpful, maybe in the CNS or in the intraocular fluid. So penetration in the CNS, we can see just 10 to 25%, okay, of the plasma levels, and do not reach the CSF. And it can accumulate in the perilimb, endolimb, as renal cortex. Where do you find this endolimb? See, just now we told these are the drugs which involve phototoxicity and nephrotoxicity. But in medial infection, where the hepatic membrane is not completely broken, okay, or it is a less severe form of drug where the concentration can be achieved maximum is this drug. Okay, in urinary tract infection also, we cannot use this drug in severe infections because it is an nephrotoxic drug. But the drug reaches the site in its active concentration. That means in mild to moderate conditions, this will be the drug of choice. Okay. So that points we need to remember, though they are toxic at those sites, still they are used in their infections. So volume of distribution can be increased in leukemias, and elimination is by glomerular filtration, and most of it is excreted unchanged. So both chemo and peritoneal dialysis can be used as among the rest of this. It is important because these are drugs with narrow therapeutic index, such as dioxin or lithium. Okay, we need to remember the drugs with narrow therapeutic index, and if it is in excess, out of our control or related toxicity, we need to know the methods of removing those drugs, that is chemo and electrolyte dialysis. So antibacterial cell spectrum we have just discussed, that is aerobic, gram-negative bacteria, Enterobacter, E. coli, Proteus, Shigella, Pseudomonas. They are very less effective against anaerobes, and also they are less effective against gram-negative bacilli, gram-negative cocci, gram-positive bacilli, and anaerobes. Here we use this streptomycin. Initially it was used for various purposes. Now it is restricted to tuberculosis. Okay, streptomycin and vancomycin used against tuberculosis. Amikacin, gentamicin used against urinary tract infections, and also for Streptococcus picalis and Pseudomonas aeruginosa. So the drugs acting against Pseudomonas aeruginosa can also be a short notes. We will start taking the list of drugs which can be active against this. So we are telling you that this is a toxic drug and is a drug having narrow therapeutic index. And for that we have a term here, therapeutic drug monitoring. Okay, so this is a procedure where we exactly maintain what should be the plasma concentration of the drug. Okay, like we have very narrow therapeutic index and the drug's range should be within this narrow range. And this is a very costly affair, and this is done in the tertiary care hospitals where the other drugs we cannot give in such patients, and only drugs effective by the post antibiotic drug may be this group of drugs. Have you heard of the term antimicrobial sensitivity?